everybody. Thank you so much for joining us. This is the AO Trauma Hand North America online series, 3 cases, Fireside series, and today's topic will be wrist arthritis. Chairperson for AO Trauma Hand is Marco Rizzo. He's currently at the Mayo Clinic, professor of Department of Orthopedic Surgery, as well as the chair of the Division of the Hand Surgery in Rochester, Minnesota. My name is Nina Sue. I will be your moderator for this session today. I'm an associate professor at the Department of Orthopedic Surgery at Emory University in Atlanta, Georgia. We're very fortunate to have our sage here as Amit Gupta. He's a professor at Department of Orthopedic Surgery at the University of Louisville in Louisville, Kentucky. Our faculty for this session will be, again, Marco Rizzo, again, professor, Department of Orthopedic Surgery, chair of the Division of Hand Surgery at Mayo Clinic in Rochester, Minnesota. And the hand therapist that will save us all will be Janine Beasley. She's a professor at the Occupational Science and Therapy at Grand Valley State University in Grand Rapids, Michigan. We're very excited to have you come join us today. Sorry, I'm having problems. So disclosure information is enclosed. And then all potential conflicts of interest were mitigated prior to the start of this webinar. So content validation statement I'm going to be making for AO North America. It's an independent nonprofit surgical specialty society. It's dedicated to improving the care of patients with musculoskeletal injuries. AO does not endorse or promote the use of any product or service of commercial entities. And equipment used during or spoken about during this course is for demonstration teaching purposes only, and the intent is to enhance the learning experience. So here's our agenda. I'm currently in the process of going through the welcome, opening remarks, and as well as the introduction. I will do a very short case 1, and it's really to introduce the concept of wrist arthritis, which is our topic of choice today. And then the next one will be our sage. We'll present case 2, how I do it. And it's really going to learn from his experience and as well as how he does it, as well as the lessons learned. Case 3 will be by our faculty, and they will be for navigating complications. So he will present actually multiple cases of different complications and what they've learned. Last will be a therapy discussion, and Janine and Dr. Beasley will be talking about therapeutic considerations that we have to think about with these surgeries. And then we're going to do a case discussion with panelists. I will help moderate. I'll also look through the Q&A. I'll bring up questions that anyone has. And then we'll do some closing remarks. So we have about 75 minutes to go through this session. So this is the learning objectives. We want to be able to identify radiographic indications for surgical procedures, identify and understand clinical criteria required for the indication of the procedure, define appropriate surgical anatomy and surgical steps in the execution of the procedure, and recognize potential pitfalls and develop strategies to avoid them and methodology to deal with them should they arise. Lastly, we're going to review pertinent literature regarding procedures being discussed and its outcome, and all 3 talks will have that. So as a reminder, so this is the first of 9 different sessions, and it's a wonderful speaker series. I do recommend it. And this is also on the left side, you'll see that there are webinars as well. That's hand specific, and I would recommend joining them. They're free of charge, and they usually run from 8 to 9 p.m. Eastern. Lastly, if you want to access this recording because you've missed it or missed a portion of it, a link of the recording will be sent out via Zoom for all those that registered. And this is being live streamed as well as the other talks and other talks for AO through Ortho TV. All right, so now we have concluded our introduction, and we're going to start with our first illustrative case. We have a 71-year-old male, chronic bilateral wrist pain, does have a history of crystalline arthropathy, and this patient is really just to illustrate the concept of wrist arthritis. So if you look on the right as well as left, there's joint space narrowing as well as early arthritic changes in both the radiocarpal and midcarpal joints. And it's evidenced both on the PA as well as lateral views, both sides. Patient is symptomatic. So although this patient has crystalline arthropathy, there's many causes for wrist arthritis. So osteoarthritis, you can also get wrist arthritis from post-traumatic arthritis, whether that be a SLAC, SNAC, radius malunion, or non-union may develop into wrist arthritis. You also have to worry about sequelae of septic arthritis that leads to wrist arthritis and Kienbock's. And of course, you cannot forget inflammatory arthritis. There's many inflammatory arthritis. I just wrote RA, but certainly there's others that you definitely have to consider. Options are significant, or there's gradations to your options, and you always want to start with non-operative management. So non-operative management encompasses quite a lot of different options, and some of our other speakers will speak about this as well. But you want to, of course, modify. If it's hurting, stop doing it, or change the way you're doing something. You want to do activity modification. You want to maybe advocate a brace to help offload the wrist after they've done the activity or before they're going to do the activities. You can also consider medications, whether that be oral or topical, as well as hand therapy potentially earlier on, and intra-articular injections if they're starting to go through the different modalities and they're not finding relief. Options, however, when they've completely maximized non-operative management, there are certainly operative interventions that we can consider, and this is a small selection of potential options. Unfortunately, given our time restriction, we can't go through them all, but I did want to at least highlight that there are not just one solution for wrist arthritis, and you have to really consider the patient, the radiographs, as well as what the functional outcomes that the patient is looking for. So you can have wrist denervation, and some surgeons will include an arthroscopic synovectomy or radial styloidectomy. You can have proximal row carpectomy, and there are open options as well as arthroscopic techniques mentioned in the literature. You can have four-corner fusions as well as other three-corner fusions to try to increase your radial ulnar deviation. Again, that can be an open versus arthroscopic methods. You can have total wrist arthrodesis as well as total wrist replacement. So these are just selection of the options. So for this patient, the patient obviously received on the right side, was very symptomatic, received a total wrist arthrodesis. So what does the literature say about total wrist arthrodesis? So if you look at the union and complication rates out of total wrist arthrodesis, there was a systematic review recently done, looked at approximately just under 4,000 total wrist fusions. And, overall, union rates are good. And there's many different options in how to do a total wrist arthrodesis. And this systematic review and meta-analysis didn't really show a significant difference between techniques, but it's not without potential complications. And they reported a complication rate of approximately 16%. Of course, total wrist fusion, you lose all motion in the wrist. So it's often compared to total wrist arthrodesis versus total wrist arthroplasty. So this was looked at 43 studies, 17 total wrist fusions, 24 total wrist arthroplasty papers, and 2 were matched cohort studies. And they found that actually functional outcomes significantly improved. Patients were relatively happy with both procedures. Pain were similar, but grip strength improved significantly pre versus post-op. Complications, however, in this paper did show that the total wrist arthroplasty had a little bit more complications versus the total wrist fusion. But of course, each generation of implants is getting better. Our survival is getting better. It's not perfect, but it's certainly improving. And this systematic review highlighted that as well. So what do you do about the left side now? Had a arthrodesis on the right side. So for the left side, really what our goals are to address the pain. And at this point, they've lost motion on one side. Now the patient is looking into preserving motion. And really what you want to do is maintain the longevity of results. You don't want to keep operating on this patient every 2 years potentially. And so this patient actually received a total wrist arthroplasty on the contralateral side. So if you look at a systematic review, and this was a recent one just published in 2024, it looked at just under 400 total wrist arthroplasties, and they found improved DASH and pain VAS scores in both groups of total wrist arthroplasties, inflammatory and non-inflammatory arthritis. Historically, it's always been that you would do total wrist arthroplasty for rheumatoid patients only, but certainly those indications have expanded quite significantly over the years. And there was no statistical difference in terms of the outcome, whether it was an inflammatory cause for the arthritis versus non-inflammatory. And they found that total wrist arthroplasty improved the PRWE scores in non-inflammatory patients, although not necessarily inflammatory patients, because obviously they have multiple other joint issues at that same time. And I would like to thank you so much for listening. So what I'm going to do is I'm going to stop sharing, and now we're going to go on to our sage. Dr. Gupta is going to proceed and tell us how he does it.
Thank you, Nina. Thanks for the introduction. Going to talk about management of wrist arthritis with total wrist arthroplasty. I must tell you that I was one of the designers of the Remotion Total Wrist, so I have some conflict of interest. Now, in this management of wrist arthritis, we'll talk about anatomy of the wrist. You already heard about the genesis of wrist arthritis and also about traditional management options, including proximal rocopectomy, limited and total wrist arthrodesis. And of course, these are the traditional management methods which have been practiced for many, many years. We'll talk about slightly about evolution of total wrist arthroplasty and talk about the design concepts of the particular implant and some clinical cases and some clinical results. And then Marco will talk about complications and how to deal with them. Now, the wrist is beautiful anatomy, both dorsally and palmarly, and this is all destroyed, of course, in the wrist arthritis. And our job is to try and see if we can get some motion. So the evolution of design has been this was started by Swanson with silicone interpositional arthroplasty, Swanson and Niebuhr in 1967. And subsequently, following this, people said, well, if we can do the silicone, why can't we do implants? So ball and socket articulations started in 1969 with Muley from Bern with Mark 1 and Mark 2. And there are a whole bunch of other implants which came in, trispherical voles, and some of them were very little used. Now, there's also from Switzerland, Geschwin, Scheer, and Baller. And Muley, they had a very big ball and socket with large flanges in the distal and proximal part. Had a lot of problems with these, and especially when you took them out, you had to take out a lot of the wrist. So Voles tried this type of implant, and again, the problem was loosening. Trisphericals were used for a while, Figge from New York. And then from Mayo Clinic, the biax wrist, Dr. Beckenbaugh, with long stems into the third metacarpal. And obviously with long stems came long problems like penetration through the cortex of the metacarpal, etc. And you'll hear some about it. And also it required excision of a large portion of the wrist. Other implants which were very rarely used came in, large screws were put in, long stems. And then people said try to make it a hinge implant, but of course the wrist is not a hinge, and that transmitted a lot of stress onto the distal and proximal part. This is the third generation biax with the stem going straight into the third metacarpal and screws going into the carpus and into the metacarpal. So the design concepts was that rationale for surface replacement. You do a surface replacement, you maintain the anatomic joint contour, kinematics of the joint towards the normal. You preserve all the dorsal and volar support and preserve the soft tissues and try to give improved motion and stability. The advantage is retain the cortical structure of the distal radius and thereby retain all the ligamentous insertions. You try to mimic the center of rotation to the normal motion, and you preserve, if the distal radial joint is not involved, you preserve the distal radial joint. So we try to do this design with cobalt chrome alloy with titanium coating for better ingrowth, anatomically shaped intramedullary stem, distal face match the volar tilt and ulnar inclination angles. And we chose an ellipsoidal articular surface to approximate anatomic centers. This was chosen a long time ago, before any of the finite element studies came out. Just intuitively, we chose a ellipsoidal articular surface. And I'll tell you a little bit about the subsequent biomechanical research. And there was a deep articulation to promote inherent stability, because you don't want to put anything in a cast, and did not require excision of the radius or the ulnar head. So again, there's a spherical ball, proximal face to articulate with the carpal ball. There was a carpal ball which is made of polyethylene insert, which has a 10 degrees of rotation in the carpal component and allows for some absorption of stresses going into the corpus. And the distal part was made of the carpal plate, which had a stem which just went into the corpus, not into the metacarpal, not a long stem, and two screws, one on the ulnar and one on the radial side. So the thing is, the bar is very low, that we only need very small amount of movement in the wrist for function. Palmer estimated that we need extension of about 30 degrees, flexion of 5 degrees, radial deviation of 10 degrees, and ulnar deviation of about 15 degrees. So with the minimal joint resection, press fit into the distal radius, a distal screw fixation, and you can get about 40 degrees of extension, flexion, and 30 degrees of radial deviation. Now, you know that in many of the rheumatoids, you can get a fusion between the proximal and distal row. Now, when this happens, that you can maintain or keep all your fixation in the corpus, and that will prevent any transmission of load into the metacarpals, which seems to be a main problem with the first and second generation implants. So we try to maintain all our fixation of the corpus. And the other thing is, and I must emphasize this, it's not been emphasized enough, we try to promote intercarpal fusion so that this helps in the stability of the carpal plate, because that is one of the main problems that has been present in wrist arthroplasty, that you get loosening of the carpal side. So in order to prevent that, you promote fusion between the carpal bones. So in the early version of this surface replacement, which is J. Menon's implant, it had a toroid design. Toroid design is a section of a donut, and by definition, a donut is unstable. So you roll a donut on the table, it just falls off. So they used to get a lot of dislocations, and then Brian Adams and others did this finite element study, and they found that the ideal surface is an ellipsoid, and that's why their design was changed to ellipsoid rather than a toroid. But we had already done this many years ago with intuitively, without any biomechanical backing to our design system. So this was the radial cup, and then we had minimal bone resection, uncemented cancella screws into the corpus, and the ultra high density ellipse, and we had some angulation of the screws and carpal curvature. We cut out the volar side to prevent tendon impingement, prevent nerve impingement, and then there was a press fit carpal component and an ultra high density insert which rotated somewhat to allow for sudden absorption of forces. So this is our basically the design. And people have done biomechanical studies on this, like finite element analysis, and this has been done with the implant and in rheumatoids, and it shows that the putting the implant smoothens out the forces that are transmitted to these various joints. So it almost comes back to the normal alignment. This is a very nice study from Malaysia. So clinical cases, this is how we do it. I'll just go through this process. A dorsal midline incision is made, and then what I do is I take the retinaculum and I make two flaps, one radially based, one ulnarly based, and then there are a whole bunch of there are a whole system of these devices which allow you to guide it into the metacarpal. But the main focus is that it should be center point of the radius in APN lateral direction, and center point along the third metacarpal. So third metacarpal aligns with the radius. As long as you can get that, you can do this freehand also, but you can use the jigs to help you do this implant, and these jigs are always available and you can use them. So basically you put in the jigs, find the center point of the radius, and then you make a cut which goes at the base of the tip of the capitate and hamate, and takes out half of the scaphoid, all of the triquetrum, and all of the lunate, and then you find the center point of the third metacarpal and put in your carpal guide in that, and this just reams the radius and takes out the subchondral bone, and so you make a groove for the application of the radial component. So and once you've got that, you find the center point of the radius to put in the guide, and you take x-rays which will show you whether your wire is right in the center of the medullary canal, and you got to make it more valgus than varus, and then you drill it, you make a medullary canal brooch, and then you put in the trial implants, and then on the carpal side we would put in a guide and then drill the capitate to the central point. And you can do this, it's pretty open, and you can find the capitate in AP and lateral planes even free-handed, which is the center point. And then the two screws, one will go into the hamate, which is a shorter screw. The other screw goes across into the base of the second metacarpal, and that fixes it. So then this is a very stable implant and does not dislocate. So this is our first case. This is the very first case, which was done in 2003. And this patient had a four-corner fusion, which did not work, and so I had to take that down. So you see medial and lateral flaps, the distally based capsular flap, and then taking out the previous hardware, making a broach into the radius, putting the carpal plate, putting the radial component in, and this is the ultra high density polyethylene insert going in. And you can see that amount of bone that's resected is very small, and if it fails, you can always resect bone and you can fuse it, because that's the ultimate salvage for this. And then you repair the ligament, and you use one of the retinacular flaps to lengthen the dorsal capsule, so that gives you a better flexion. And the other retinacular flap is used as a true as a retinaculum for that. So one goes volarly and one goes dorsally. And this was the early one, and he went in for almost 15 years without any problems. Unfortunately, he's passed away now. So this is another lady, 72 years old, post-traumatic wrist arthritis. Patient had wrist arthroplasty and did very well with good range of motion for good 16, 17 years. This gentleman has been done quite recently. He has wrist arthritis, crystal arthropathy, post arthritis, and total wrist arthroplasty. As you can see, center point into the capitate, one into the hamate, one into the base of the second metacarpal, the screws, and he has excellent range of motion. This patient had a fusion of the wrist, which he did not like, did not fuse either, so we took that down and put in a wrist arthroplasty, and here it is with the wrist arthroplasty here. So there may be problems in secondary situations where you take down a wrist arthrodesis, or you do it for a failed four-corner fusion. You may have tight spaces, maybe may have difficulty in finding anatomical landmarks. There'll be contractures, there'll be DRUJ problems, there'll be nerve problems, tendon problems, or rehab problems. Solutions will be wide exposure, and we need to do a liberal use of intraoperative imaging. You need to create space for the implant, the amount of implant. So what I do is I put two laminar spreaders, one on either side, and stretch them, and then wait for a little bit, use the viscoelastic force of properties of scar tissue, stretch them again, and clear everything, all the soft tissue, all the bone off the volar capsule. Don't take out the volar capsule, but clear off all the bony fragments. And we may have to do a carpal tunnel release, and certainly get careful hemostasis. So this is a patient who had a failed proximal row carpectomy, and I see this a lot. So failed proximal row carpectomy, you can do a fusion in this, but the patient did not want to have fusion and wanted a movement. So here we put a the laminar spreaders on either side to stretch it out, create space. And then I take out the pisiform. And you can use the pisiform because if you have a proximal row carpectomy, there isn't a distal part of the scaphoid. So build bone, you can use the pisiform to fix that. And then put some bone graft and to do intercarpal fusion. So this is a retinaculum which lengthens the dorsal capsule, and this patient then, despite the revision, got excellent range of motion. And this is her wrist at 12 years. So again, excellent range of motion, which is maintained. Patient had this type of arthritis. Again, intercarpal fusion with bone grafting. As you can see, intercarpal fusion between the capitate and the hamate, between the triquetrum, between the hamate and the radial-sided bones. And so indications are rheumatoid arthritis. You don't want to do it in a very advanced stage or where there's no bone. Then that sets up the implant for failure. You can do it for SLAC stage 3 or 4, Kienbock stage 4, or severe pancarpal arthritis. So clinical results, favorable results, which were published by Bucksteins, Herzberg, and others, 65 wrists in 60 patients, follow-up for 5 to 9 years. As you can see, the pain score improves dramatically. The quick dash improves. The range of motion improvement is not that great. So you'll get the similar range of motion that you started off preoperatively, maybe a little bit better. Implant survival has been fairly good with this implant. Have been studied in long term by Herzberg, Bucksteins, and others. So here's the Herzberg's study with rheumatoid and non-rheumatoid wrists. The 5% to 6% complications, survival rate is 96 to 92%, and there was improvement in the VAS scores, dash scores, range of motion, and grip strength. With this, the arc is changing. We are doing more and more non-inflammatory arthropathy as total wrist, and the long-term survival curve is fairly favorable, with improvement in VAS scores and quick dash and range of motion. Again, other studies. One of the things that we've noticed that sometimes you get these cysts around the proximal part, that is around the radius, and these are probably stress shielding cysts. It's been seen, and Bucksteins and others did long-term studies on this. They couldn't find any wear particles, so it's been thought to be from wear, but could not find any wear particles in this. Could be stress shielding, and these stabilize after a year. And if necessary, you can always excise them and graft them. There's always good fixation of the proximal part of the stem, and the radial stem is not loose. Sometimes the carpal stem could be loose if there are cysts in there. I think Marco will talk a little bit about that. And so wear particles were studied in Buckstein's article, and they did not find any wear particles. So we've talked about anatomy of the wrist a little bit, total wrist arthroplasty evolution, design concepts of the remotions, and clinical cases, and some clinical results of total wrist arthroplasty. Well, thanks very much.
Thank you so much, Dr. Gupta. So next will be our faculty, Dr. Marco Rizzo, and he's going to be showing us some cases on how to avoid those complications, or at least think about the complications.
Well, thank you, Amit. That's just wonderful. And Nina, every time I listen to Amit, it's just splendid to learn from you. Can you see my slides okay?
Yes, we can.
Okay. I have no relevant conflicts. And I'm going to take you through a case. This dates back, 15 years ago. If you go back and you can... It's 15 years ago now. This is a patient with rheumatoid arthritis who has, you can see the range of motion, and she has pancarpal arthritis. When you look at her DREJ, you don't appreciate that there's a lot of obvious DREJ arthritic change, at least on an X-ray. I mean, these two areas are kissing, but she's quite painful with the DREJ, so it necessitated us at least considering an intervention for that. And in this setting, we thought she was strongly interested in a motion-preserving option, and we felt that, practically speaking, the only real motion-preserving option was an arthroplasty. What to do with the ulna is still debated even this day. You know, could you do a ulnar head arthroplasty? Yeah, you could. Could you do a DERA? Most people, I think, would do a DERA in this setting. Probably not an SK if you're considering an arthroplasty. So I think those would be the surgical options you could consider. You could do mass resection, of course, which are variants of, or a hemiresection interposition, which is also a variation of the distal ulnar resection, at least in my book. And this is what we did. This is her at 2 weeks post-op. and she's quite happy at this point. Again, post-op pain improved. Even now she's noting that she's having less pain. And she's now being released to, after another couple weeks to protect the ulna, she was then released to go ahead and start range of motion. And this is her 3 months post-op. She has no pain, quite nice arc of motion. Well, at least a functional arc of motion, and better than what she'd had preoperatively when you look at the wrist flexion and extension. I'm going to take you through this case as it is a complication case, spoiler alert. And I'm going to take you through several lessons learned from a single case, and hopefully it'll be helpful and educational for you all. This is her 1 year post-op, and one thing I'd like to share is what's going on at the ulnar head. And if you look at the sigmoid notch, you can appreciate that there's erosion of the ulnar head into the sigmoid notch. There is an advantage maybe to that to some degrees, that it helps to stabilize the ulna. The disadvantage is it can be a source of discomfort. And even when we looked at this in non-rheumatoid patients, erosion into the sigmoid notch is not unusual. Sometimes it can be quite significant. And one of the lessons that I've learned, first lesson, is that if you do a DRUJ replacement with an ulnar head in a rheumatoid patient, I don't think it's a good idea, especially if they've had a previous, if they have a total wrist arthroplasty. So I no longer do ulnar head arthroplasties in the setting of these patients. And this is why, largely. This is a different patient, of course. This is a rheumatoid who had bilateral ulnar head arthroplasties, arthrodesis on the left side and arthroplasty on the right side. And the erosions can be quite extensive, and it's quite disheartening to see this degree of erosion. The other thing to remember about ulnar head arthroplasties is that they don't go out easy. It's a lot of work to get them out. You often have to go to great efforts to break the implant bone interface and to try to jack it out. If you look at these two U heads, there's a significant amount of bone missing, and that's all stress shielding, which means that she has really well fixed ulna down here, and it's a bear to get these things out. So if we go back to our original patient, here she is at 4 years post-op, and she has further erosion, but thankfully clinically doing well. And here she is now at 6 years post-op, and now there's a new development. In addition to the erosion into the sigmoid notch, there's this cystic change that Mitt was talking about. And you can almost appreciate that there's a well-fixed pointed stem, much like Dr. Gupta did say, occurs routinely in these cases. And this is this is probably, I believe, related to stress shielding. I'm inclined to agree that it is. But this can be worrisome and can be quite extensive. Thankfully, again, clinically doing well, although she's lost some of her motion over as she's progressed. So 6 years post-op, still not painful, but still with a functional arc of motion, some radiographic changes that are concerning. Anyone intervene here? Probably not, in my opinion. I'll answer my own question here. I don't feel that I have an easy answer for these cases, and I've relegated myself to saying, well, gee, when do you intervene for someone with osteolysis? Do you wait for it to become symptomatic? But by that time, you may not have enough bone to really try to even consider revision, and you're left with a fusion. To me, most of this, and this is another one of my lessons that I'll share later, is that when these things fail, I pretty much lean right towards a fusion, as it's the most predictable solution for failed arthroplasty. Not in every case, but in most cases. Again, lesson 2 is we're not sure what causes the osteolysis, although I personally think it's stress shielding. And again, this is that study that Amit nicely highlighted with Michelle Beckstein, which was quite an ambitious study. They looked at blood samples. They actually took pathology specimens of these patients, and they did find, as Amit said, no real clear link to polyethylene debris or metallosis being the culprit. And they identified and classified radiolucent zones. They found that most of them, as Amit suggested, stabilize after 3 years. But again, unlike hip and knee arthroplasty, osteolysis and total wrist is not obviously linked to polyethylene debris or metallic debris or inflammatory reaction related to those. Now here she is at 7 years post-op, and things have gotten a little bit more complicated. There's a broken screw at the index index metacarpal screw, and which clearly suggests that there's maybe micromotion at the distal component, and again, clinically not painful and slightly less range of motion. The area of osteolysis seems, at least on this view, to be maybe not quite progressing as rapidly it had up until this point, and the sigmoid notch erosion is more pronounced, it looks like. So the third lesson from this case that I'd like to share is that distal component loosening is the biggest problem in total wrist arthroplasty. And Amit highlighted this a little bit too, and so did Nina in the introduction. It's the most common reason for reoperation in the literature and in my own experience. And when we looked at our series of 400 in total, over 400 wrists done in a over a 30-year period, we found that far and away distal loosening was the main problem related to failure. And it seemed to be more concerning in younger folks. And as we alluded to in previous studies, that it was less likely in the newer generation studies, in the newer generation implants, that is. But distal loosening was associated with worse outcomes overall. The wrists that had no distal loosening tended to do notably better, as you might expect. Further to that point, even when we look at revision total wrists, when we look at 76 arthroplasties, which we followed for over 10 years that were revised, the main problem with failure of revision arthroplasty is, again, loosening, and is, again, most often distal component loosening. So distal component loosening seems to be the bane of of total wrist at this point. If we can solve that problem, I bet we'll go a long way towards really changing how many hand surgeons think about treatment of wrist arthritis. Interestingly, pain relief is very predictable, even in the cases of loosening. So it becomes a clinical dilemma. When do you intervene? And again, as I mentioned earlier, I relegate it to when they become clinically symptomatic. This leads into one of the lessons I highlighted earlier is the most predictable solution for failed total wrist is a fusion. And even in our series, looking back at 2011, this was many of these were pre-locking plate. We used to use diamond pins to fuse these when they failed, and the results were not super great. 52% fusion rate. Thankfully, even when they didn't fuse, most patients had pain-free wrists, but did require potential hardware removal for the non-union. So a fusion after failed arthroplasty is not a slam dunk. However, with the newer technology, Brian Adams showed us, and our own experience has highlighted this, maybe not quite the success that Brian Adams has cited with 95% fusion rate. We've had improvement of our fusion rates with the use of better technology, and we do follow a protocol. Many of these have large defects, and structural allograft or cancellous allograft from a femoral head, a cadaver femoral head, is really helpful in these cases, and often supplemented with DBX and allograft. And this seems to be the best formula for trying to get these to fuse. So here's this patient at 9 years. Now the distal component is clearly loose. She's collapsed further. She is at a point where she's symptomatic, and this takes you through the surgery where we remove the implant. Again, not easy to remove the implants. This K-wire helps to break the implant bone interface so that you can preserve bone, and the same thing you can do with the U-head or the ulnar head arthroplasty to remove. And if you take your time, you can preserve the maximum amount of bone. In this case, we didn't feel that we needed to lengthen the carpus. She had had enough bone loss at the ulna, so this did not concern ourselves with impingement. So in this case, we used the femoral hood allograft as a bone graft, a cancellous graft, more than a structural graft. And you pack the intervals, and this is her X-ray intraoperatively. And this is her X-ray at 2 weeks postoperatively. And it looks good here radiographically, but sadly she got infected, which leads into another lesson learned, which is independent of the wrist arthritis, but more related to the use of calcium sulfate. My hope initially was to try to keep the plate, given that her infection occurred fairly acutely, keep the plate and use antibiotic beads to remedy the infection. And if you're too ambitious with the calcium sulfate beads, you can generate drainage and prolonged heal and interrupt the healing process, and ultimately undermine the success of your outcome. So while I tend to like them, be careful when you place them too superficially or too much of it. It can lead to persistent wound drainage, and this has been shown in numerous studies looking at complications related to its use, in addition to some patients who have hypercalcemia related issues. So be careful with that as well. So ultimately I washed her out and I took out all the hardware and I put her in a cast for a long, long time. And ultimately she ended up looking like this at 6 months post-op. And we highlighted this a little bit earlier, but the last lesson I'll share is that resection arthroplasty is not always a bad thing. Many of these patients have no pain, and they sort of stumble into a situation where they get a jog of motion. And this is her at 3 years post-IND and resection arthroplasty. And there's a lot of lessons learned in this case for me, and hopefully some that we can share. But it's important to realize that these complications can occur, and while motion is wonderful, it can be an ambitious treatment for wrist arthritis can result in complications. And again, it's beyond the scope of this presentation to have discussed all the treatments for wrist arthritis, but hopefully these cases highlight some educational value, and particularly as we use it as related to wrist arthroplasty.
Thank you, Dr. Rizzo. So before you go, I'm going to ask you, what if the patient had a lot of pain and developed a non-union after you pulled? What would you?
Oh yeah, well, it's that's a great question. And early in my career, even when I had a wrist fusion that failed, my initial impulse was to go ahead and replate it and bone graft it again and try to do a triple Lindy. But I will caution you that maybe that's ambitious. There's probably a lot of patients that I overtreated and failed in overtreating. So the conversation's different. It's not just for wrist, it's for, small finger fusions, CMC fusions. If you just remove the hardware and tell them that's probably, hopefully, all we need to do, and you'll have a little jog of motion, you will likely be happy. And it's not just, wishful thinking. If you look at our fusion, we did a paper looking at fusions of thumb. We had a 15% non-union rate. Over half of those patients had no pain. Over half. We looked at PIP arthroplasty, arthrodesis after failed PIP arthroplasty. Our fusion rate was 60%. Most of the ones that had a non-union were pain-free. We look at our wrist fusions after failed arthroplasty, 52% fusion rate. and most of the ones who didn't heal were pain-free. So I've learned to just sort of encourage them to get the hardware out and see how the dust settles, and it has served me very well as a way of talking them through these problems. Now, if they have pain, of course, after you take out the hardware, then then you'll have to address it in some manner. But thank God those instances are very rare.
Dr. Gupta, I'm going to ask you too, that's for that same case. Obviously, that case is a series of disasters. I think I probably would have broken down and cried halfway. So Dr. Gupta, what would you have done? So you do the total risk, then you have a fusion, then obviously it gets an infection. So now you've pulled everything out. And if the patient continued to have pain, what would you do in that scenario?
Well, I would agree with Marco, number one, that certainly DREJ arthroplasty is not an indication in rheumatoids, especially the one which doesn't have a sigmoid side replacement. So, but to answer to your question, if once you get a problem with the fusion, I would attempt to fuse it. I would in a rheumatoids, as we know, wrist fusion does well for their overall hand function. So I would still attempt to fuse it, but cancellous graft or corticocancellous graft, and still try to fuse it.
Okay, thank you. All right, next we have Janine Beasley, who's going to be talking about the therapeutic portions for wrist arthritis. Thank you.
Thank you. Well, it's really an honor and a privilege to be part of this fabulous panel, and I hope that the therapist perspective will be of interest to the group. We know we've talked about the rheumatoid wrist, and it's quite common in about 50% of all patients in the first couple of years with rheumatoid arthritis, and 90% after a longer period of time. And so I just really need to talk a little bit about the conservative management before they get to you very, very briefly, because we have some articles that have been very supportive of, for example, from Ramsey, a simple wrist orthosis prior to thinking about surgery has been demonstrated to reduce pain, improve grip, and most of the patients prefer a well-fitting soft orthosis as opposed to a rigid orthosis for some of those wrist conditions. Now, with the zigzag deformity, we're looking at, of course, ulnar deviation of the fingers, which gets all of the attention, but what's happening at the wrist is quite serious. And so we need to look at that as we make a nighttime orthosis, which is also shown to a nighttime orthosis for our patients with rheumatoid arthritis and ulnar deviation, zigzag deformity. It actually decreases pain and increases grip strength when they wear it at night, because they start out a little more stable with their day. And so this is a little inside out strap. Now, you surgeons like to show your surgery. I'm so sorry. We therapists like to show our splits. So you have to see what we do. And this is a little inside out strap technique that actually pulls the metacarpals away from radial deviation into neutral, and the little pads bring the fingers into neutral. And patients really appreciate this orthosis as well. So also, Dr. Rizzo talked about the distal ulna, and conservatively, now, sometimes you can be very helpful to those very painful patients who aren't quite ready for surgery with a simple wrist ulnar support. And there's been 2 studies that show it increases weight bearing capacity, especially with TFCC issues, and decreases pain. And so this is just a simple little technique. What I like to do is test it first to see if my orthosis is going to work. And that is, I take my thenar eminence and depress the ulna, and then pull up on the radius and bring them into pronation and supination. And if that decreases their pain, then they may really benefit from a simple soft orthosis with these little pads. And not everybody's ready for surgery right out of the gate. So this might be something that can be very helpful for rheumatoid, TFCC, those types of conditions. And what's nice is this doesn't cross the wrist, so they can do a lot of stuff with it on. And if they have their own orthosis, you can also put those pads on the ulna and up on the radius, one that they have already, and say, hey, does this decrease your pain with pronation and supination? And they're typically very happy. We've talked about post-traumatic arthritis, and with SLAC and SNAC, and a thumb spica is going to need to be used conservatively, possibly. Pizotriquetral osteoarthritis, you can go with a wrist orthosis. This is an interesting patient with still disease that I saw early on, who had that same trouble with their ulna. You know how that's kind of a landmark or sign of still disease, and she was very happy to have something so she could take care of her kids. And we as hand therapists also do a lot with joint protection for these patients, which has been demonstrated with multiple studies to be very helpful. And we have lots of modalities that the research has been supportive, as far as different types of heat, especially paraffin with the rheumatoid and osteoarthritic patient. Pulsed ultrasound as opposed to continuous ultrasound has been helpful. And low-level laser therapy has some mixed evidence with rheumatoid arthritic patients. But so what do we do now post-operatively? Again, this is a quick talk. I'm fitting it all in. But for example, with synovectomy, a wrist orthosis is going to be utilized, and you can pretty much start, in most of those cases, active range of motion pretty quickly. And, some stiffness with the rheumatoid patient may be desirable because you don't want to overstress, and they are walking a balance between stability and mobility in those cases. We've had wonderful talks tonight about the total wrist arthroplasty, and they may be placed in a wrist orthosis just after surgery. We want to be gentle with these. As you can see, there can be problems. So to starting active range of motion, but we want some motion. I think patients who have a fusion on one side and a wrist arthroplasty on the other, I think what you want to keep in mind is they should be able to get to both ends of the gastrointestinal tract. Does that make sense? For feeding and for those other activities. So full range of motion may not be indicated, but nicely being able to get to do those activities of daily living. And we're not going to start passive range of motion any sooner than the 4th week. And we're going to talk to the surgeon about it, and also delaying any resistive exercises and letting them know that there is a weight restriction with these. Wrist arthrodesis, hey, same orthosis, same splint. And they may be wearing that for, as Dr. Rizzo said, maybe a long period of time, depending on how that fusion is going. So postoperative management for the distal ulna, there's a lot to be said there, multiple procedures, but they may come out of that short arm cast into a wrist orthosis, but more often into a sugar tongue or Munster orthosis, depending on what was done. We're going to, and typically range of motion to the wrist is not started until about the 4th week. I'm sorry. And, therapists in the audience that are making this splint, the Munster and the Munster here and the sugar tongue here allow wrist or elbow mobility somewhat, where if you just make a long arm orthosis, you're going to restrict that elbow. These sugar tongue orthoses are a pain to make with one big strip of material. And here, this wonderful pattern from my friend Debbie Schwartz is very easy to make for the Munster. Gravity helps you and can really kind of limit that motion, or, until it is time or removed for exercises once range of motion has begun. So I'm kind of a Munster fan. So I hope that this was helpful, talking some of the conservative things and the post-operative things. Appreciate that we have this team with surgeons and therapists, and also listening to our patients. And if you're in Grand Rapids, come visit me at Finkelstein Hall. So these are my references. Thank you.
That was wonderful. So Janine, I think for all hand surgery, like my hand therapists, I've been very fortunate through my training as well as my employment, have the best hand therapists. I do great work because they do great work and things. But I had a question. One, of course, of hand surgery is edema control. So what is your like some patients I find are almost too scared to do anything with the hand. So it's like I tell them it's fine, you can do it, and they just won't do it. And they'll go to the therapist, they'll try, but then when they go home and they don't. So what do you do when the patient gets really, really swollen, can't move the hands? Like how do you do that? How do you manage that? What's your preferred technique?
Well, the first thing is to really look at teaching them how to elevate with activities of daily living. Don't just say elevate, but just say, okay, when you get to the table, the elbows down, and thinking of a raindrop going downhill when they're in bed. See, they think, oh, it's next to me, it's elevated. Well, it's not elevated. That raindrop will not go down and down. Slight compression devices can be very helpful as far as isotoner gloves, active range of motion, and also the massage and things we do in therapy. If you can get a spouse involved in the massage, if there's trust there, that can also be very helpful. But you can sometimes measure it, give them that feedback and say, okay, here's your measurement before we've done the massage, here it is after. You can see how effective this is with just one therapy session. Please keep doing this because it's going to avoid a lot of problems. So.
Then you mentioned some other modalities, so like pulsed ultrasound. So when do you start employing these? Like,
well, it's going to depend on the surgery that's done. I'm not a big user of ultrasound with implants, although the research says you can. It just kind of makes me worried with that. But using pulsed ultrasound actually decreases the inflammatory effect with the cellular membrane, and as opposed to continuous ultrasound, that's going to put heat into that situation. So if you've got kind of a hot, angry situation, a pulsed ultrasound can be very effective.
I'll ask also Dr. Rizzo and Dr. Gupta, like, so obviously both of you have an extensive experience with total wrist arthroplasties. What do you think your learning curve was? I'm sure you're learning, I think patients humble you all the time, but was there a certain point where you thought, okay, I have a handle on how to do my total wrist arthroplasties or getting over the tips and tricks? So Dr. Rizzo, maybe first.
Yeah, I'm happy to chime in. It took me, I think, 5 years before I really started to feel like I got the hang of it. Obviously, I don't consider myself like a savant or someone who's just technically just gifted, So for some folks, I'm sure it could be faster. I was blessed to work and continue to work at a place where we do a lot of arthroplasty, so I think that was helpful for me. I think it's a hard thing to do one of these a year or one every other year. It's probably going to take longer because you have to relearn and relearn. But I think probably folks who've designed implants, like Dr. Beckenbaugh designed the Biax, and Dr. Cooney helped design the Remotion with Dr. Gupta. They had some insights, and the time I spent in the cadaver lab was helpful when we were helping other folks who had other designs, wanted to test them. I think that was very valuable. So I think a lot of those factors play into your learning curve. I do encourage you, if you're going to embark on doing wrist arthroplasties, to spend some time in the cadaver lab and really get used to. And one of the key things I think Dr. Gupta mentioned, among many key things, was don't limit your exposure. Your exposure is key. Make sure you can see. Make sure you have a handle on what you're doing. You're only going to get one chance in certain things. You're only getting one chance on the cut. You're only going to get one chance on the alignment. And once your alignment's off, the struggle, the rest of the case is just a struggle. It's just not, it's miserable. So make sure you don't sell yourself short and give yourself enough time to do the procedure. When you're young and just starting, I underestimated sometimes how long they would take, and even now, there's curveballs you get depending on what you're doing, especially in cases like Dr. Gupta showed, where you have something that's failed, like a failed four. We see more and more of those now, more and more failed PRCs, more and more failed four corners that ultimately patients want to preserve motion, don't really want to go to that fusion yet. So those would be some of the things that I could happily share.
Well, I was in a privileged position. In my training, I'd gone through some of the failures of the second and third generation implants. So I was working with Uli Buchler and Byrne, and I saw some of the muleys that he was doing in those days, or had been done before, and he was trying to revise them. So I kept on thinking there must be a better way to do a total wrist arthroplasty. So we kept on working in the lab to try and see if we can get a better handle on this. And we're talking to and working with Jay Menon. That came the concept of having a fusion in the carpal area and limiting the fixation in the distal carpal row. So as I was developing this implant, I went to the cadaver lab many times, and as Marco mentioned, being in the cadaver lab and doing your cadaver work really helps with your learning curve. Became very familiar with the anatomy and the approaches of the wrist and how to deal with all the problems with that. And then we basically try to develop a system such that it would not require very complicated procedures. So we wanted to keep it simple as possible. The complexity could be in the design, but you don't have to, as a surgeon, as an end user, you don't have to see the complexity. Just like an Apple product, it's there. The iPhone is there. You're working with it. The iPad is there. You're working with it. There's a lot of complexities in the software, in the hardware, but you don't have to appreciate that. You just have to keep working on it. So we tried to make a design which was easy to put in, and all you need to do is center on the radius, center on the capitate, and you can do it freehand basically. So exposure is good, important. So over the years, we developed multiple tips and tricks, and one of the things is to make a wide exposure, get a nice capsular flap which is distally based, and then do these retinacular flaps, which are, one is radially based, one is ulnarly based. Because if you then put one of the retinacular flaps deep to the tendons and expand your the dorsal capsule, so it will give you better flexion. And then if you are and then get the space. If you're doing a difficult procedure, release everything, get spaces, take out all the bone from the volar capsule, stretch it out, and then get some bone, intercarpal fusion. So when you take out the bone from the radius or rest of the carpus, you use that bone to pack in between the intercarpal spaces, so you get a good fusion, solid fusion, so your distal fixation is solid. And once you do this, a few times, you get better and better at it. So going to the cadaver lab, going to some courses where you learn the technique, if you're doing the first time, and then going to the cadaver lab, practicing it a number of times, is the easy way to help with your learning curve.
How about, obviously young patients are becoming much more active, but you certainly have some young patients that develop wrist arthritis. They're not interested in fusion whatsoever. When do you start getting nervous, or when do you decline maybe pursuing a total wrist? Like age-wise, I mean, do you have like an age cutoff that you would not consider total wrist arthroplasty?
Well, obviously, you would not consider somebody age 20, 30. I mean, you have GRAs, but unfortunately, with the new drugs, those situations are rare these days. So I have done it in 40 plus patients, and there are patients who are pretty active. They did not in any way want wrist arthrodesis, and people come and they kind of demand wrist arthroplasty. Understand that once your wrist becomes pain-free, they are not going to listen to you on any restrictions. They're going to do exactly what they want to do with their life. So if these people can get 5-10 years of good wrist motion, and then if you have to do a revision or you have to do a fusion, that I think is worth it. And some people feel that it's worth their time spent in that. So I've done it in younger patients in 40 to 50 year age group, but I try to limit it in the older age group in the post-traumatic situation.
What about you, Dr. Rizzo?
Yeah, I'm pretty, we have had a lot of experience with failed total risk, so we we tend to be a little bit, you know, um, some folks though, they really can't stand the idea of a fusion, and we've taken down, much like Dr. Gupta showed, we've taken down fusions to do total risks. I don't have hard and fast rules. I've done JRA patients in their 30s who've had total risks, and then prepare them for stage 2, a risk fusion somewhere down the line, just so they're aware. But clearly, you want someone who's going to be lower demand, older. I mean, that failed total risk, we saw that people under 60 had a higher failure rate. So that's clear. I think that's pretty much established. But it's more nuanced than just simple dogmatically saying this is where my cutoff is. I think you have to individualize each treatment for each patient and just talk them through with the risks. And again, of course, they're going to lean on us for guidance, but I think having an informed patient really helps them make the best decision for that individual patient.
And then just a question in the Q&A was, have you found any difference in the outcome of wrist fusion due to wrist fusion in arthritis, like so either wrist arthritis or infection? Have you noticed any difference if you're going to do a wrist fusion after those scenarios?
Obviously, on wrist fusion, you'll have technical challenges in the presence of infection. You'll have to get rid of the infection. You have to put antibiotic beads. You have to put antibiotic spacers. Then certainly put them through a course of IV antibiotics. So all those things, plus you may have to take out more bone. So it's a little bit more challenging than doing a primary wrist arthrodesis. And then the use of allograft, you may have to use either autografts or make sure that your infection is completely controlled. So presence of infection in that question is certainly a challenge for wrist arthrodesis.
And then another question in the box is about what would you routinely use for your first line for treating periprosthetic joint? So you have a total wrist arthroplasty. Well, do you have a preferred first line antibiotic?
It'll depend on my culture results mostly, and consult with my ID colleagues.
Well, I will have to say, if there's no other questions in the Q&A, I thank everybody for participating in the session. I always learned so much with Dr. Gupta and Dr. Rizzo, and it was such a pleasure listening to Janine Beasley's talk too, because hand therapy I think is so important, and I learned something new every day. I always thought the Munster was difficult to do, so I have steered away from it, but apparently it's super easy. I will continue to private well. So definitely a learning point. Thank you everyone for joining us.
Thank you.
And certainly if there's any questions, you can reach out to any of us privately. Take care.